Lovely to see you here. So I'm Angela Ballantyne. I'm a member of the Bioethics Centre, but I'm based in Wellington at the School of Medicine here. And my background is in genetics and genomics and then bioethics. So I will share these slides. Can you guys see that?
Yep, great.
Yeah. Awesome. All right. So this is a paper that I started writing in 2019. And it's one of those papers that's sitting at about 90%, 95% finished. And if anyone is like really interested in this and wants to co-author it with me and help me get it across the line, yeah, please email me afterwards. I think it's kind of mainly there and I sort of know what I want to say. Yeah, but also if you've got any feedback, because like I said, this hasn't been published yet or even submitted, please do let me know because, yeah, I'd love to see how it lands with you. So basically, the problem that I'm interested in is an issue that's been raised in the literature reasonably recently, which is in relation to pragmatic trials. And I'll explain all these terms in a minute. But essentially, pragmatic trials are part of what is sometimes described as a learning healthcare system. And this is an approach that really tries to integrate research and learning activities into the clinical space. And that's challenging in several ways, one of which is because it sort of challenges that split between clinical practice and research and the different ethical and regulatory norms we have around those two activities. When we integrate those, a range of new issues arise. So one issue that apparently has arisen is a concern that when researchers are doing research in real world environments, they might realize through the research that usual practice or standard care, stuff that's sort of just generally going on in the clinical space, is suboptimal or doesn't meet best practice standards or is below a particular harm threshold. And in those situations, do the researchers have an obligation to warn patients, not that they're at risk of harm from the research, but that they may not be getting the best standard of clinical care in the clinical context. And this is a problem for two reasons mainly. One, if researchers have this obligation, that's really costly and expensive and time consuming and may act as a barrier to doing these pragmatic trials. And two, in some cases, it might actually undermine the scientific validity of the study anyway. And I'll give you a case study to show how that might play out. So really what I'm interested in is understanding when might there be a duty to warn patients about the standard of clinical care they're receiving that comes to light in a pragmatic trial. So here's some terminology. Learning healthcare systems are systems that integrate research and clinical care using routine patient health information to evaluate effectiveness. And two types of trials you might see in a learning healthcare system are pragmatic trials, and they evaluate the effectiveness of interventions in real life routine practice conditions, and comparative effectiveness research, which compares established treatments, for example, standards of care, and services to determine which is superior, for example, in terms of efficacy or safety. So these differ from kind of our traditional conception of explanatory trials. In explanatory trials or interventional trials, they're typically like a new intervention and a very tightly controlled research context where the participants are recruited and screened, often patients of a particular age or weight or with comorbidities are all excluded. And so the data that you get from a research trial may not be applicable to the entire patient population. So learning healthcare systems really aim to generate knowledge from real world patients, for example, that are taking have multi-morbidity and polypharmacy, are taking lots of different drugs and see how those are interacting, for example. So it's not an alternative to explanatory trials. It's really an approach that seeks to be in addition to interventional or explanatory research. And so this idea about learning healthcare systems isn't new. I mean, I suppose it was proposed really maybe in the early 2000s, but has garnered a lot of interest recently. So this is a really famous or kind of well-respected account of the ethical values of learning healthcare systems developed by Ruth Baden and her colleagues in the United States. the Institute for Medicine in the United States set a goal in 2007 that by 2020, 90% of all clinical decisions would be supported by accurate, timely, and up-to-date clinical information and will reflect the best evidence available. So that was, clearly now quite optimistic in terms of the degree of progress we would make in relation to learning healthcare systems. But I think as much as we haven't kind of necessarily implemented learning healthcare systems as much as people would have liked, I think it's certainly a big focus on the horizon. As we look at electronic health records, big data research, precision medicine research, all of that is about taking the data from a population as a whole and seeing what we can learn from that. This is just a little study that looked at publications that mention learning healthcare systems, and you can see that the interest in this kind of approach has increased dramatically in the last sort of 10, particularly last 5 years. Now in New Zealand, this is like a lot of this focus has come out of the US, and the studies and the literature I'm going to talk about today is predominantly US based. But there is discussion of pragmatic trials, for example, in the National Ethical Standards in New Zealand, and they do flag that one of the concerns is this idea about standards of care. So what if you notice that clinical standards of care are problematic in some way, as well as issues around ancillary care when you do pragmatic trials. So here's essentially the problem. If researchers are conducting pragmatic trials and they identify cases of suboptimal care, for example, in the control arm of the trial, do they have an ethical duty to warn these patients? And as I said in the intro, this is problematic because warning patients is both costly and could undermine the scientific integrity of the trial. So this proposed duty to warn is potentially quite a major barrier to pragmatic research and the benefits that might come from that. This is the literature that I'm essentially responding to. So there's this first really influential paper, as I said, from Ruth Faden. That's the team that did that sort of like house-shaped, the 7 pillars of ethical practice in learning healthcare systems. Then there were 3 papers that came out in 2019, which is when I started writing this response. And these are by really well-known scholars in research ethics in the US. And then more recently, a paper that brings forth some of the same ideas more recently in the American Journal of Bioethics this year. So here's the case study that's discussed in a number of these papers. So it's a study called IMPACT, and it's looking at atrial fibrillation, which is basically like an irregular heartbeat. So it's a randomized pragmatic control trial. And this is a real study. So through looking at clinical records, they had identified 80,000 eligible patients in the United States who had a diagnosis of atrial fibrillation, but had no documentation in their clinical notes that they had been prescribed oral anticoagulants. So this is the best practice therapy and as described in kind of clinical best practice guidelines for patients with AF. What the study wanted to do was test this educational intervention. So send out like an educational pack to both patients and clinicians in 50%, so 40 of the 80,000, about the importance of OAC therapy, oral anticoagulants. But what's worth noting is that the 40,000 patients who were in the control arm, who wouldn't get this educational intervention, they just had usual standard of care. They weren't being denied any care that they would otherwise be entitled to. There weren't any additional risks. And this educational intervention was not of proven benefit at this point. And in fact, we now know that it had no benefit. So it didn't change prescribing rates for those that received it. There would be no patient consent. So this was approved under a consent waiver under the US guidelines for the common rule. And note that one of the criteria for getting a consent waiver is that the research needs to be minimal risk. So even from the outset, we're not, even if patients are receiving substandard care, from a research perspective, this hasn't been identified as a high risk study. Now, you might argue, well, that's because the educational intervention is minimal risk. The granting of the consent waiver doesn't tell you anything about whether the usual standard of care is minimal risk. And that's a fair argument. And it's somewhat ambiguous in relation to pragmatic trials, whether anyone is assessing the standard of care, the kind of the usual arm. And there's no restrictions on clinicians' practice. This is typical for pragmatic trials. You're not constraining what clinicians do in their interactions with patients. You're sort of seeing how things operate in the real world in usual practice. And so they'd follow patients in the intervention and the control arm for 12 months. Now, in this context, as I said, the issue was raised. Well, actually, that means we'd have 40,000 patients with this diagnosis who are not being prescribed this medication, which is in line with best practice guidelines. And is that a problem? So the first thing to note is that if you look at the literature and those papers and many others in this area, there is just a massive variability of the terminology that's used to describe this ostensible problem. And that's often just a sign that this is, a new issue in bioethics and one that still needs quite a bit of kind of conceptual work. So here are some of the terms that are used to describe when this duty to warn might occur. In respect to usual care, unmet health needs, incompetent care, problematic clinical care, potential shortcomings in care, substandard care, suboptimal care, or a shortfall in care. And so, I kind of hope that you can see there that there's actually like a big variability in what those standards might constitute. And often these terms are used interchangeably in the same paragraph or in the same paper, at least. So first point is that I think there's a lot more normative work and conceptual work that needs to be done in this space. So at a start, I would divide those terms into three potential categories. The first is where actually care is probably actually totally fine. So this is care that would be good, but suboptimal. And I think it's really important to note that we don't expect clinicians to be perfect in every interaction they have with patients. And that's actually totally, an unreasonable expectation. So optimal is defined as what is the best or the most favorable of a range of potential interactions. And we know that our healthcare system doesn't provide optimal care in every single case. And in my view, that's totally fine. That is as someone who has done therapy around the issue of perfectionism, and spent like a lot of time thinking about like what's good enough versus what's perfect. But that to me just seems like a really obvious first step in terms of clarifying issues in this debate. Then we've got a set of standards, which I think are a bit more ambiguous. So these are standards which simply refer, almost descriptively sometimes, to what happens in usual practice. And some of these might be okay and some of them might not be, but we would need to interrogate that a bit more. So we might have unmet health needs. Of course we have unmet health needs, right? No health system meets every patient's health needs all of the time, right? So every health system has unmet health needs. Maybe those unmet health needs are fine, right? Because there's been a resource allocation decision that means we prioritize a different intervention or a different set of patients. And maybe they're really unjust and inequitable and not acceptable. But in and of themselves, we can't necessarily judge that just from the terminology itself. Potential shortcomings in care. Again, I think this is usual care, obviously, and potentially problematic clinical care. So all of these, I think, are in this category of it's a little bit ambiguous. They might be okay or they might not, but we would need further context to determine that. And then there's a category where standard care is unacceptable. So this would be incompetent care, substandard care, or a shortfall in care. And I think the main thing here is that there's a difference between a threshold of optimal care and everything that's under that, and a threshold of inadequate care, substandard, unacceptable care. And certainly some things that happen in the health system are unacceptable, right? And in the New Zealand system, those might be cases that end up at the HDC. In the US system, that might be stuff that results in a medical negligence claim or a medical malpractice claim. And then there's a whole bunch of stuff in the middle that's standard care, which might not be perfect, but broadly, on a day-to-day basis, we're all accepting that that's okay in its imperfection. No one's suggesting that those hospitals are shut down. No one's suggesting debarring those clinicians. No one's suggesting shutting down that surgical unit, for example. I'm going to move this little thing around. Okay. Now, that to me seems really not that interesting and kind of obvious, but I think it's worth pointing out that actually a lot of the literature in this area refers to the idea of optimal care being what is required in clinical practice in the context of these pragmatic trials. So if we go back to that really influential learning healthcare framework that was proposed by Ruth Faden and colleagues, you can see here that one of the 7 ethical tenets is that each patient in a learning healthcare system is provided with optimal clinical care. Now, in line with the kind of conceptual confusion that's going on in this space, they later in the paper define that as research activities shouldn't impede the net clinical benefit that a patient would expect to receive, which I think is starting to sound more like usual clinical care rather than optimal clinical care, but it's certainly the language they use. In relation to the impact study that I was talking to you about earlier, the question was raised by the Project Oversight Committee. If care may be suboptimal and the researchers are in a position to do something about it, shouldn't they intervene and not just aim to study it? So here, the implication is really that anything that falls below that suboptimal bar is so problematic that there's an ethical duty on researchers to intervene to address that rather than just studying what goes on in a clinical system. And sort of other areas of bioethics, other bioethicists have argued that this optimal standard of care is what's required. So the normative standard of care required of physicians is what's regarded as best practice in view of current scientific knowledge and expert opinion. So to me, it seems really obvious that we shouldn't be requiring clinicians to provide optimal care, but certainly that is a prominent view in the literature. Okay, so the next question is failure to follow best practice clinical guidelines in and of itself unacceptable care? Certainly, I think can plausibly be defined in some cases as suboptimal care. Whether it's substandard is another question. And so in their most recent paper, Stephanie Moraine and Emily Largent argue that when care is inconsistent with clinical guidelines, this amounts to a shortfall in the patient's care, suggesting that really when clinical practice isn't in line with clinical guidelines, that's unacceptable, right? That's a type of harm to the patient. It's a shortfall in their care. However, we know that non-compliance with clinical practice guidelines is as high as 70% in terms of patient interactions, occurs across almost all disciplines and countries. And this has been demonstrated by, in a range of studies. And we know, for example, specifically with atrial fibrillation, that in the US, as many as half of high-risk patients, so that's not just all patients with AF, that's patients with AF who are also high risk, don't receive oral anticoagulants, right? So it's not just that a few patients are missing out or occasionally clinical practice doesn't align with best practice. Actually, that happens all the time. And there's good reasons as to why that might happen. So clinical practice guidelines, and I have to thank and acknowledge Ben Gray for helping with this section of the paper and previous iterations of it. So clinical practice guidelines are based on evidence at a population level. And while that might be accurate at a population level, there might be several reasons why a general practitioner might not follow them in relation to an individual patient. So a couple of these might be maybe they're actually on the medication, but it's not documented in the clinical notes. So the clinical notes might have missed that. Maybe they offered it to the patient and the patient declined. So as we know in New Zealand and overseas, competent patients are entitled to refuse medically indicated care or care that's prescribed and recommended by the clinician. So we can't assume that just because patients' notes don't have this prescription listed, that they weren't offered it and didn't decline it for personal reasons. There's a question of adherence and treatment burden. So sometimes patients start a medication and then stop it. And there's increasing focus on treatment burden. So a recent paper which looked at 6 common sort of chronic health conditions said that for a patient who had 3 out of those 6, which isn't uncommon, right? So you might have 3 chronic common health conditions. If that patient followed all of the clinical best practice guidelines, they would be taking 6 to 13 medications a day and doing 50 to 70 hours of health-related activity per month. So when we just look at one condition, you can see, why the clinical practice guidelines might recommend quite a lot in terms of specific behaviors and medication. But actually for patients who have multi-morbidity, by the time you add each of those ones together, the treatment burden can become quite high. And so both the clinician or the patient might decide, actually, your atrial fibrillation is kind of a lower issue relative to other things you've got going on. And so we're not going to bother, or we're not going to choose to prescribe this at the moment. There's often cultural, religious, and social reasons why care might not align with best practice guidelines. So abortion's a really good example of this. There's really clear clinical best practice lines around abortion, but countries and states choose for social and religious and cultural reasons not to follow those, right? So treatment around alcohol, so alcohol intervention treatment is another example where Muslim countries might not follow those guidelines due to religious objections regarding alcohol. So just because there's clinical evidence that a certain behavior or set of strategies for a particular health condition is clinically best practice doesn't mean that that necessarily aligns with the cultural expectations in a particular country or clinic. There's also the issue of polypharmacy. So again, clinical practice guidelines are often based on an individual disorder or condition, but we know that polypharmacy is an issue. That's patients taking multiple medications. Now, 81% of standard clinical trials exclude patients with multimorbidity, right? So there's very little and limited evidence about polypharmacy and how specific drugs interact. So that might be a reason, again, why the GP has decided not to prescribe one particular medication if the patient's already on a range of other medications. Maybe that's contraindicated. Maybe they're just concerned about it. Maybe the patient, for that reason, doesn't want to take more medication. There's a question of out-of-pocket cost. So again, just looking at the clinical notes won't tell you how much, and in different jurisdictions, whether a patient has to pay for that medication and whether that's how much it costs, whether it's subsidized, how feasible that is. And then finally, in general, in primary healthcare generally, there's kind of a growing concern that a lot of clinical research looks at outcomes that are easy to measure from a clinical perspective, right? So biomarkers, for example. But trials often don't measure outcomes that actually matter to patients. And often these are issues around not just length of life, but quality of life. And coming back to those issues around kind of treatment burden. And so the extent to which the benefit that's offered by any particular intervention, whether that's outweighed by the cost physically, financially, in terms of time and energy of adding that to a kind of patient's treatment regime. So there's a whole range of reasons why in an individual case, a individual clinician may not prescribe or a patient may decline to have a particular medication. So it seems to me really problematic to just say that all patients whose care doesn't align with clinical practice guidelines are receiving problematic care. So then we can think about, okay, so even if we thought there was something potentially problematic here, it's not as though just informing the patient of that, like fulfilling this proposed duty to warn, is cost-free, right? So there's a range of costs and harms that go along with contacting patients in pragmatic trials and saying your clinical care may be problematic. So the first is that the notification process itself is really costly. So if you're looking, in that impact trial of notifying 40,000 patients that they should potentially be on anticoagulants, postage alone for that might be $45,000, right? Often that's outside. And as we all know about the funding squeeze in research in New Zealand, that might be outside the cost of the trial. There's then also the budget of the trial. There's questions about who notifies the patient. So often pragmatic trials happen without specific consent, or maybe opt-in consent or altered consent. And this is what happened with the impact trial. So there was a consent waiver because it was deemed to be minimal risk, couldn't be plausibly conducted without the consent waiver, and wouldn't adversely affect patients' welfare substantially by being included in the trial. That means it can be really sometimes inappropriate and confronting for patients if a researcher rings them or a researcher writes a letter and says, we were doing this pragmatic research study that you didn't even know you were enrolled in. And as a result, we've looked at your medical notes and found that you should be receiving this drug. So many people think that's inappropriate. The suggestion in the literature at the moment is that it's better for institutions who are involved in the pragmatic design to take on that notification burden, and or clinicians. But again, thinking about that in New Zealand at the moment, where we've got a massive problem, with our primary healthcare staff leaving and being overburdened, to turn around and say to them, well, from a research perspective, we've decided that what you're doing in usual care is so substandard that we're going to write to all of your patients in the first place. But actually, we don't want to do it. We want you to pick up the ethical burden of contacting your patients. I think that's, not going to fall well for good reasons. And it's not clear if clinicians picked up this notification obligation, whether, who would pay for their time to do that as well. If it's not covered by the research budget, it's not clear that it's covered by clinical care budget. And then there's threats to the kind of research relationships in the first place. So if you do require patients to be notified, there's, I think, genuine threats have been, and this is based on research with stakeholders involved in pragmatic research. It does threaten that relationship for researchers to come in and say, actually, we think that the standard of care here is so problematic that we need to notify people at an institutional level and also at a clinician level. So there's a real worry that that will just turn institutions and clinicians away from supporting a kind of learning healthcare system approach to knowledge generation. There's then concern that it might cause actually anxiety on the patient's behalf and might threaten their trust in the doctor-patient relationship. And again, the view here is, I guess, probably some of those patients should be on oral anticoagulants, but maybe many of them don't need to be, and for the reasons that I talked about, and causing patients anxiety about that potentially unnecessarily could be a problem. And then there's the concern that actually, if you notify thousands of patients that they should be alert to possible undertreatment, that is going to flow into a lot of additional clinical appointments, which we know there's already, wait lists for at the moment in terms of people's things that are already on patients' own agenda as being high needs, something they really want to prioritize going to the doctor for. So now we're kind of generating more on that list without necessarily kind of a good substantive reason, and possibly additional tests down the road, whether those are blood tests or in another context it might be scans or other kind of investigations, all of which can be costly to the health system. So fulfilling this proposed duty to warn isn't cost-free either. We can look at what patients might say about this. Now, unsurprisingly, if you go out and ask patients, would you want to know this information? All of you are going to know the answer to this, but patients will always say yes. And this is consistent with a lot of patient research, right? If you ask patients, do you want more consent over your health data? Do you want more control? Do you want more information about your genomic risk profile, about your health? They pretty much always say yes. However, we know in practice, two things happen. One, patients think they want that information, but often when they actually get it, they either don't act on it or it causes anxiety. So it actually makes them worse off. And second, we know in more kind of substantive research, often that's like focus groups or citizens' juries, if you can really talk to a patient group about the harms that come from knowing some of this information. So for example, genomic risk, risk information that's very like low risk, often they can see the harm that comes from that. So that's the kind of the first instinctive response is like, yes, I want to know. But I think we need to take that perhaps with a little bit of grain of salt, that kind of initial response, and some of the research that looks at patients more kind of more considered responses, I think is worth taking into account. So this was a recent study, again, by the same sort of group of researchers in the US, where they did focus groups and they looked at, this stands for Pragmatic Controlled Trials, which show collateral findings. So findings that come out of the research, which, the examples we're just talking about, which weren't sort of directly related to answering the research question and what you should do with that information. And in this case, the focus group asked people about, well, actually, if we looked at your medical record and found that you were prescribed a medicine that was contraindicated, and we let you know about that, how would you feel? And so this shows that patients actually have kind of a range of different responses. It generates fear that they might have a significant health problem. It generated anger that the medication had gone unnoticed by their clinician. It also went along with anger, sometimes it being included in research without their permission, as well as eliciting gratitude that the information had been shared. And what came out strongly in this study was they really wanted their treating clinician to be informed that this had happened and to be part of the conversation moving forward regarding whether they should be on this medication and, follow-up questions. So this suggests, as we sort of saw in the last slide, that actually notifying patients of this is likely to put stress on the doctor-patient relationship and certainly generate more kind of clinical appointments with the clinician to resolve this particular issue. All right, so when is there a duty to warn? This would be my response. So rather than saying there's a duty to warn whenever care is suboptimal, I would have a much higher threshold. And so this is what I'm proposing. The first question we can ask is, does this routine clinical practice depart from the standard expected of an ordinary skilled practitioner operating in the field? So here you might need to look at a group of practitioners. So you might be looking at specific practice in a particular clinic, right? So does the management of back pain in this clinic look particularly different from how we would expect that to be managed across New Zealand? We could use the example of the Bristol surgical pediatric unit, which was that example with the whistleblower anaesthetist, where actually if you looked at the data from that unit, their rate of complications and pediatric cardiac mortality as a result of the surgical interventions were much higher than we would expect in comparable parts of the National Health Service in the UK. So, and the people I think that should be doing this are essentially peer reviewers, okay? So this is other medical practitioners doing a kind of peer review in this area and saying, no, actually, I think this is just standard practice. It doesn't meet, maybe there's some areas where it doesn't meet best practice guidelines, but that's totally normal in New Zealand. And from a kind of medical perspective, we don't see that as a problem. Second question is, are there grounds to believe that routine practice, so that delivered by an ordinary skilled practitioner, falls short of patients' entitlement to services of a reasonable care and skill? And I think this question is especially relevant with respect to aspects of clinical care that aren't related to diagnosis and treatment. So this could be, for example, around consent and communication. And this kind of two-pronged distinction really follows Ron Patterson, one of our previous HDC commissioners, views that when it comes to questions around appropriate clinical care that relate to assessment, diagnosis, and treatment, the appropriate way of determining that is to speak to clinicians and see what their expert view is. When it comes to questions of communication, consent standards, referrals, follow-up, so those are more kind of relationship issues. Actually, there is a role for other bodies, for example, a research ethics committee or an HDC review committee, to say, okay, from a clinical perspective, you might all be doing this, right? You might all be doing consent in a particular way, or all doing disclosure in a particular way, but actually that doesn't meet what patients are normatively entitled to. And so a really good example there is clinicians saying, oh, we all do unconsented intimate exams when patients are under general anesthetic. That's common practice. We all do that. But there is an appropriate role for a review body there to say, actually, but that's not okay. And that doesn't kind of meet what patients are entitled to in terms of reasonable care and skill. And then the third example would just be really unexpected findings that are kind of totally outside the frame of what you anticipated to find in the research, that are unlikely to be noticed in routine clinical care, represent a really significant threat to life or health, and are treatable. So in the first study, it was really obvious because it was the premise of the study, that half of their 80,000 people weren't on this particular medication. What I'm thinking about more in this third example is if you're doing reviews of brain scans, for example, to look at something completely different, or you're looking at osteoporosis scans, and in one of the scans you happen to notice that there's a tumor of some sort. And because this isn't on the patient's radar in any way, it's very unlikely to be be picked up in routine clinical care. It's unlikely to have been something that was discussed. See, in the atrial fibrillation context, the patient has that diagnosis, right? The patient, it says on their clinical records, they have that diagnosis. The patient's perfectly able, if they want to Google what's the treatment for atrial fibrillation. And it's plausible that medication has already been discussed with the patient. In this kind of category of cases, I'm thinking more of cases where it's just really an unexpected finding. So if it's unlikely to be picked up in routine care, represents a really significant threat to health or life, and is treatable in some way, then I think there's also an obligation to warn patients. But this is quite a high threshold, right? So I don't think the duty to warn, as it's currently interpreted in the literature, is operational or is necessary. So I really would move away from thinking we have a duty to warn when care is suboptimal, and would propose instead a much higher harm threshold, and argue that there's really only, in my view, a duty to warn in one of these three situations. So I'll leave it at that so that there's some time for questions. Thank you very much. And I'll stop sharing.
Thanks, Angela. Everyone was clapping, but I don't know if you heard it because
that's fine.
Thank you. I'm muted quickly enough. So we'll just change the view so that we can see. Right, so there are the online participants. As our usual protocols, we start with online questions first. So anyone out there have a question for us? It's nothing. Let's move to the room. Anyone? Oh, great. Grant.
Well, I thought that was an excellent paper, Angela. And I think the point that you come down to, that even if in some respects the care could be considered scientifically suboptimal, there is a genuine and participatory role for the patient as an intelligent partner in therapy. Now, the reason you'll see that that's been consistent with what I've written for the last 30 or 40 years. But in my own particular case, where there's atrial fibrillation and a possible risk of a stroke and all that kind of thing, and yet I have all that background, clinical neuroscience knowledge, my GP completely raises the question every time that I might be on slightly suboptimal care, but he says, I know you know that, and we have an open discussion about the anomalies I allow in my own clinical care. And of course, I try to do my bit for him because I attend physiotherapy department clinics as a volunteer for them to learn on. And they regularly take my blood pressure and pulse and oxygenation levels. So he's not left in the dark as to where I am between his checks. He knows that in the background, I am doing something to provide him with the information he needs to make an informed and patient-sensitive ongoing clinical decision. I think that's broadly in keeping with what you're saying.
Yeah, that's such an interesting personal example. Thanks, Grant. And I've noted down some of the language, the intelligent partner in therapy. I really love that. Yeah, so I'll make sure that I can cite some of your work in relation to that. Thank you.
Any help you want with this paper, seeing as all the hard lifting seems to be done, I'll be more than happy to offer.
Oh, thank you.
I'll drop.
I would love that.
Online.
Awesome. Yeah. Thank you so much.
In a gap after a book at the moment, so can help you.
Very fortuitous timing. Thank you.
Good question.
Yeah, just a couple of little comments on the guidelines as a clinician.
Mhm.
Guidelines are often 5 to 10 years old, so you could be correctly ignoring them by following new research. Also, in my area of practice, psychiatry, you can have, in New Zealand, you don't have guidelines, but the Australians have guidelines, the English have guidelines, the Americans have guidelines. They have vastly different recommendations based on the same evidence for highly politicized reasons. So even if you assume a guideline is correct for a disorder, which guideline? And then the third is sort of a higher level comment. When you think about single variable decisions, like atrial fibrillation, it's very easy. But when you're treating a patient, you're looking at 100+ variables for a single decision. And then those sort of really procedural single variable ethical decisions really fall over, because you're sort of, in the statistical analogy, you're moving into fuzzy logic, complex computing, Bayesian statistics, away from t-test. Does this matter? Because none of those guidelines factor in lifestyle choices. Desires to be at children's weddings, the meaning of taking a medication which has for a patient the fact that their mother died from being over anticoagulated. Like, there's too many variables that are just not capturable in a guideline.
Yeah, that's really helpful. When you were mentioning that there's different guidelines that based on the same evidence for political reasons, I mean, the one that I can think of is kind of, the abortion care stuff. Although actually in the US, the clinical guidelines are still reasonably sort of clear about that, or more consistent than you actually see the variability in practice. Are there any other examples that you were thinking of specifically that I could have a look at?
Well, I know for psychiatry, the depression guidelines between Australia and the UK very, very, very much, very widely about where they place medication in that program. And that's not an evidence-based choice, that's a resource decision.
Yeah.
And whether you have a public healthcare system, you'll go heavy on the non-medical interventions, but Australia has a lot of private stuff, so they go very heavy on the medical interventions because that is a benefit to the private psychiatrists.
That's really helpful. Thank you so much. I really appreciate that.
Yeah.
Josie's got a question, and then Andrew Moore online. So,
hey, thanks, Angela. I'm sure that you're doing the right thing by pushing on that thing about what does optimal care, is that really the standard, etc. That seems like you've convinced me. It feels like everyone. Can you tell us two things? One is the duty to warn. Where does it come from, and is it a duty to warn why is it a duty to warn the patient and not the provider? So there may be a reason. What's the kind of backside of that, or the kind of behind the scenes of that? And then the second question I had was about how that's different from audits. So presumably when organizations do audits of their care, there's some kind of trigger of when do you then have to act on it, and then and presumably when it's an audit, you contact the clinician and say, I've noticed, we've done an audit and you are one of the practitioners who's, giving out a lot of opioids, and we just want to check on something like that. Why is this feels so different? What's the difference?
Yeah, great questions. And those would have been good to do in the setup. So thanks for that prompt. So to answer the second question first, the duty to warn, it comes out of a research ethics approach. And so with audits, typically it's within the same institution, right? So the whole idea of an audit is that you can use health information that was disclosed for treatment and clinical reasons for an audit without consent, because audit is considered to be within the broad scope of what a patient would understand would be done with that data, in part because it's typically by the same institution. Now, whether that institution's Te Whatu Ora or a specific hospital. So the obligation, I mean, maybe there is an obligation, but it's not written about in the research ethics literature, right? Because it would be, I suppose that would be more in terms of like a health systems or a quality and safety obligation. So I don't know if that exists because I don't know that literature so well. So where this comes from is from research, from a kind of research ethics perspective, and it comes from like debates about like providing ancillary care. So for example, if you are going and doing research in a really resource poor setting and you notice that 30% of your patients, pediatric patients have worms or don't have bed nets or something, and that's really easy for you to address. And that this kind of comes from the duty to rescue. You're now in a relationship with those research participants. They're doing something to help your research. You don't have to fix all of their health needs, but if you can address some of their health needs, and there's kind of principles for when this applies, particularly at relatively low cost to yourself, in some research contexts, there's an obligation to address those ancillary health needs. Also comes out of debate, which you'll be familiar with, around kind of incidental findings in genomics. So if you're doing research and something comes up that you weren't anticipating, do you have a duty to warn? And so it's all grounded in the idea of the relationship between the researcher and the research participant, which is different from the relationship between a doctor and a patient, which is a fiduciary duty. But there's still seen to be some sort of protective, often like a protective duty that a researcher has to research participants. So as soon as you're looking at clinical data and those 80,000 people become your research participants, then you might have a duty of protection or a duty to warn about potential harm. So I don't necessarily dispute that as a principle. I just think the threshold for how we're defining harm is way too low in this context.
So it seems like a learning healthcare system should be putting its research ethics type obligations and its audit obligations on a spectrum. And that's the flip of what you're sort of, so that actually audit type obligations would be relevant for dealing with the stuff that you want to leave alone, I think.
Yeah, and I think that's part of all this conceptual work that's going on at the moment. So, I mean, I've just given you one example, but there's like lots of that, because the difference between having like clinical care and research, which are each in their own circles with their own rules and their own conception of the type of relationship that is, versus putting all that on a continuum, and often like a risk-based continuum. It's complicated on a range of levels. But I think no one sort of feels like you can just use the audit model, because research is a little bit different. But then using a full-blown kind of research ethics model doesn't work either. So there's just a lot of conceptual work in this space at the moment. Yeah.
Right, thanks, Angela. I think Andrew's question, he's realised that you have actually answered it. So I'll just see if there's any final questions from the room. Jing Bao?
Mine is somehow following Josh's question about the source of duty. Oh, thank you very much. Thank you. Such a stimulating talk. That on the other side of the coin, that the patient has a right to such information, to be informed. I have a feeling you are not arguing there is such a right in this case. Am I right?
Yes, I agree. Yeah. So I don't think the patient has a right to perfect care. I think they have a right to reasonable care delivered by, but with reasonable care and attention and skill. And so I think the same would apply, to information. I don't think they have a right to every piece of information that could be relevant to their health. That right to information about your health needs to be kind of more contextual. In terms of the resources that the health system has available, how it's prioritizing those. So I don't think the patient necessarily has a right to this. The third example that I gave, well, actually all three of those examples where I think there is a duty to warn are cases where I think the patient is entitled to know that information, so they have a right to it, but that's only a subcategory of cases where their clinical care doesn't align with best practice guidelines. And actually, that's Josie's point, which I didn't quite answer, is why warn the patient and not the clinician? So it's because of that kind of protective relationship because they're using the patient's health data for the study, that the patient is seen as the research participant with whom the researcher is now in a relationship with, even though they didn't consent to be in the study. Whereas in this case, the clinician wasn't seen as a research participant. Although if the clinician was in the control arm, the intervention arm, and they were receiving the educational information, then those clinicians would presumably be seen as research participants. But in terms of informing people, I think no one was suggesting informing the patient without informing the clinician. So you would inform both simultaneously. But the sense of the potential harm was to the patient. So the idea of like protecting someone from harm, it was about protecting the patient from potential harm.
All right, thanks, Angela. We are up to time. Are you able to stay on for a few minutes?
Yeah, absolutely. If there's any further questions,
we can do that. So just before we thank Angela, I'll remind you of next week's seminar. Marshall Wilkinson's talking on, it's just gone out of my head, but it's something to do with healthcare in the nanny state, which might create some interesting debate, and so be prepared for fireworks perhaps. Thank you, Angela. Thank you. Like totally agreement in that we don't require optimal care. It's impossible. Well, I think it is in any case. And yeah, hope you enjoy Wellington. I hope it's as nice as it is.
It is actually gorgeous here today. Yeah.
We'll go and get outside.
Yeah.
Right.
And if anyone else wants to email me or would be happy to read a copy of the paper, then let me know.
Right.
I'll definitely take Grant up on that. Thanks everyone.
All right, let's thank Angela.
If there's no further questions,
It doesn't look like there's anyone here. Yeah. All right. Thanks, Angela. See you later.
It's nice to hear from Friday. Thank you.